All right, good afternoon, friends and colleagues, and welcome to the last session for today, which is liver-directed therapy. I would like to introduce myself. I am Dr. Butch Magsambol from Singapore General Hospital.
Right, as the second talk for the liver-directed therapy session, we have Dr. Aviral Singh, who has already spoken in the morning. Just a brief introduction to someone who's not been exposed to him is he's a nuclear medicine physician who's working very closely with Professor Baum in the same center, Central Clinic, Bad Berka. Main interest being theranostics with neuroendocrine tumor and CA prostate being their mainstay of clinical work. And Dr. Aviral is going to enlighten you with intra-arterial directed liver therapy, mainly for somatostatin expressing tumors. And over to Avi.
Thanks, Ajit, for the kind introduction. So I'll talk about our experience with intraarterial PRRT in not just neuroendocrine liver metastasis, but in general somatostatin receptor expressing tumors. So for a short background, we know that patients with GEP-NEN frequently develop liver metastases that are often life-limiting factor for these patients, depending on the tumor burden. And previous works, such as by the DKFZ group, has shown that using, they did imaging studies with gallium-68 DOTA-TOC, PET-CT. For targeting the somatostatin receptors, which they could then transform this towards therapy. And it was shown with these imaging studies that the intraarterial administration led to a 3.7 times higher tumor accumulation of radiopharmaceutical compared to IV infusion in the early uptake phase particularly. Now, both preclinical and clinical studies done by the group of Poole et al. From Rotterdam showed that the intraarterial hepatic administration, which they had worked with indium 111, DTPAOC, can result in significantly increased tumor uptake compared with IV administration. So that was more towards a therapeutic approach. Now, this increased uptake in the hepatic neuroendocrine metastases will, when applying a therapeutic radiolabel analog such as lutetium, DOTA-TOC, or yttrium, which we have mainly used, it results in a higher tumor absorbed radiation dose. So this is the clinical part of the study performed by Poole, the group from Rotterdam. And you can clearly see that here, so that's the tumor in the liver, posterior images, and you can see with the area under the curve, the injected activity here is intraarterial on both graphs, as you can see here, and this is intravenous. So the area under the curve is significantly more when intraarterial radiopharmaceutical is injected. And in in patients or in humans, they were able to show that the increase in the uptake was 2.4-fold. Therapeutic success has been shown by certain studies, again from the Heidelberg group. This is an example where they have shown, so these are the before and after images on the PET scan and then on the MRI. They've shown partial remission, or a patient with multiple neuroendocrine liver metastases, a single cycle of intraarterial therapy was with 4 gigabecquerels yttrium and then 4 gigabecquerels of lutetium. And also they could see a significant fall in the chromogranin A. So with regards to our center, from 1997 to 2017, we've performed intraarterial PRRT essentially in large inoperable liver metastases mainly, but there are certain tumors where you could also inject into the primary tumors. So 55 patients were reported here. Essentially, we've done 56, but the 55 have a longer term of follow-up. So 31 males, 24 females with a mean age of 52 years. So from GEP-NENs, there were 41 pancreatic, so primaries were pancreatic, then mid-gut were 6 patients, cancers of unknown primary 2, and then from others you'd have meningioma, glomus, adrenal paraganglioma, pheochromocytoma, which we know already express somatostatin receptors. A very interesting case was this patient, very young patient with nasopharyngeal carcinoma, about whom we can talk later. So with regards to differentiation, 39 patients had well-differentiated tumor, 3 had poorly differentiated, and 16 we did not have a histology. And mostly the patients were grade 1 or 2, but 3 patients had grade 3 tumors as well. So mainly in all these patients we've used yttrium and lutetium because we do practice duo PRRT. Coming to the survival result analysis in these patients, we saw for the entire cohort of 55 patients, we saw a median PFS of almost 30 months and a median overall survival of 70 months. And this was at a follow-up of mean follow-up of 94.6 months. If you compare the survival analysis for patients with hepatic metastasis only versus patients with hepatic as well as some extrahepatic metastasis, the PFS was 33 months, and for the patients who had liver metastasis only. So that was better and also significant compared to patients with additional distant metastatic disease, where the median PFS was about 22 months. With regards to OS, in a similar comparison, so median OS was seen, where patients with liver metastasis only, the median overall survival was 76 months, whereas for patients with distant metastasis, it was 50 months. However, this was not clinically significant. However, just in absolute numbers, it was higher. With regards to safety profile, we saw G3 anemia in one patient, and there was no G4, and there were hematotoxicity, so anemia or any deaths occurring in this group of patients. With regards to leukocytopenia, there was no severe leukocytopenia, but we saw grade 2 leukocytopenia, which was eventually reversible over time. Thrombocytopenia, only grade 3 was seen in one patient. We had actually also treated 2 patients who had grade 4 thrombocytopenia, but it was not critical. They were not bleeding, and with regards to all other parameters, it was acceptable to treat them. Talking about renal function, we had so most patients had. So no patient had any grade 3 or 4, acute to subacute renal nephrotoxicity, and G2 drop in creatinine or rise in creatinine essentially was seen in 3 patients. We actually always perform MAC3 scintigraphy and also calculate the TER for these patients. So when we compared patients at baseline to, and then the repeat TR after 3 cycles, and also from baseline to 3 years after intraarterial PRRT, there was no clinically significant deterioration of TER, and neither did the deviation from baseline here show any correlation with the number of cycles or cumulative activity that was received by the patients. Similarly, we also assess in comparison to the TER, the central laboratory determined GFR, and we saw similar results on a similar analysis. So baseline after 3 cycles of intraarterial PRRT, then baseline and after 3 years. Again, no clinically significant deterioration was seen, and the deviation, the mild deviation, was also did not correlate with the number of cycles or cumulative activity. And again, no grade 3 or 4 nephrotoxicity was observed in any of the patients. It was a long list, but we certainly know that there was no liver dysfunction in either of the patients following intraarterial PRRT. So just stop on this case. So this is a 23-year-old university student who was diagnosed with a non-keratinizing, undifferentiated nasopharyngeal carcinoma with lymph node, extensive hepatic, and polytopic osseous metastasis. For almost a year, he had clinical symptoms, and he was being symptomatically treated he had hearing loss, and he had tubal drainage, until and unless he had some lymphadenopathy, which was also initially ignored, and then he went on to have progressive obstruction of nasal breathing when endoscopy was performed, and he had a nasopharyngeal carcinoma on biopsy. Further on with this diagnosis, he went on to receive combined radiochemotherapy, so EBRT2 tumor and the neck and locoregional lymph nodes. He also had chemotherapy with mitomycin and 5-fluorouracil. Unfortunately, he had fever, he had pneumonia, and then just to prevent him from getting neutropenic sepsis, he was discontinued from chemotherapy. He went on to have an FDG PET, which showed a positive left rib metastasis, which was resected, unfortunately, with R1. And the histology also confirmed that he had a metastasis from the nasopharyngeal carcinoma. He was then put on to checkpoint inhibitors, unfortunately progressed. He had EBRT to the T7 metastasis, and with progressive disease, then he was started on cetuximab, which is a monoclonal antibody against EGFR. Irrespective of all these therapies, he still progressed. Now, with a very intelligent move, the oncologist, I believe, performed molecular genetic analysis of circulating tumor cells, and he actually detected expression of PSMA. So they performed a gallium-68 PSMA PET-CT, which showed multiple PSMA with hepatic and osseous lesions. He was then referred to a center for consideration of PSMA therapy. However, the uptake that we saw on the PET scan was actually relatively low, so we decided to perform dosimetry studies. So we performed low-dose lutetium PSMA, but it was insufficient for radioligand therapy. So looking into literature previously, and also from Professor Vergolini's work from earlier times, it was shown that there is somatostatin receptor expression as well. So we performed a gallium-68 DOTA-TOC PET-CT in this patient, and he had intense somatostatin receptor expression of multiple hepatic, skeletal, as well as lymph node metastasis. And on the basis of which then we initiated PRRT. Now, this is his pre-radionuclide therapy receptor status and metabolic activity assessment. So he came to us with this PSMA scan where there was faint uptake in the metastasis. We, of course, given the nature of the disease, we did a metabolic workup as well. So he had pretty significant uptake of FDG, but everything based, all the therapy that could be done, he'd already received. So this was his receptor, somatostatin receptor expression. You can see metastasis in the liver, bone. So the approach at the time, which we've already discussed, that he had initial application of dosimetry, level, dose, or activity of lutetium PSMA, which failed to be effective. He received 2 cycles of lutetium DOTA-TOC. The first, on the second course, and obviously because we wanted to see how he tolerates the first one, there was no toxicity. So by the second one, he had what is PRRT in combination with radiosensitizing chemotherapy. We'll come to that shaded part a bit later. So this is his restaging prior to the third PRRT. So even after 2 cycles, so 1 cycle of PRRT, second cycle of PRCRT, he still had significant uptake in the liver metastases. They were large and they were significant, and we really need to target effectively at this point. So he was planned for intraarterial PRRT. So the third cycle was intraarterial with almost at the higher level of activity that we normally give, so 5.8 gigabecquerels. And this is the patient with his scan intraarterial, and this is metabolic complete response of liver metastasis 3 months after intraarterial PRRT. And to see it on cross-section, you can see very well the lower panel shows the liver metastasis with intense somatostatin receptor uptake, and compared to here where there is complete resolution. Now, with regards to his laboratory parameters, he was, as a part of associated diagnosis, he already had pre-PRRT anemia when he presented to us. However, following the 3 cycles, he did have some grade 1 leukocytopenia as well as thrombocytopenia, but one must keep this in mind that it's not only the effect of only PRRT, but he's had all kinds of treatments prior to that, which in combination can bring about this change. His renal function remained normal. What is very interesting is that his liver function, which was inflammatory markers were raised prior to PRRT, which were actually post intraarterial PRRT improved. And so this was pretty significant with regards to the healing process. And as well, I mean, before the intraarterial PRRTs or PRRT that was initiated, his INR was also high, so it was probably already starting to affect his synthetic function, although the entire volume of tumor mass was not that much, but probably the tumor was aggressive and already causing a tendency towards liver failure, which improved, after intraarterial PRRT2. So to summarize, in essence, we've seen excellent results in patients where you have high tumor burden of somatostatin receptor expressing tumors. You can either perform PRRT as a duo where you break cycles and in alternate cycles, or one-off you give intraarterial PRRT. You can practice tandem, where in the one sitting you can manage your dose of intravenous lutetium and with yttrium intraarterial. And all these methods can be feasible, and we look outside the box of just the planned 4-cycle intravenous PRRT set doses, so towards personalized PRRT. So thank you for your attention.